see it, yeah.
Cool.
Hello, web shadowers. Thank you all for attending this session today. For those of you who haven't attended this semester yet, we've updated our guidelines a little bit. You will now have to sign into a Google account to fill out the Google Forms. This means that if you don't already have a Google account, please make one soon.
Along with requiring sign-ins, we have added one more question to the Google Forms, making it a total of 4 questions and a summary, meaning you have to earn at least 75% for us to receive verification of your attendance. Also, please remember that your summary has to be well written in at least 3 sentences.
And as always, please remember that the Google form will be posted in the chat box at the end, and as well as in the description of this video.
Now, with that all being said, today we have the pleasure of hosting Dr. Schupper, who will be teaching us about neurosurgery. Dr. Schupper, you may begin whenever you're ready.
All right, thank you so much, Web Showers. It truly is a pleasure to be here to speak to you guys today, teach you a little bit about neurosurgery, my path to neurosurgery, and give you guys an example case. For those of you who logged in yesterday to see my good friend, Dr. Chris Riley, this will actually be an extension of that case, so stay tuned. So just to give you a brief background on who I am, so you guys have a better sense of where I came from. I'm a second year, sorry for the typo, I'm a second year neurosurgery resident at Mount Sinai in New York City. I was born and raised in Philadelphia and then went to Johns Hopkins University for my undergraduate education where I studied neuroscience and psychology. There, like Chris Riley, I played varsity baseball, I participated in student government, and I was very involved in research from a young age and participated in both trauma and neurosurgery research. I then went across the country to the University of California, San Diego, where I went to medical school in La Jolla, California. Now, I don't just operate, I like to do a lot of things outside of the hospital, and my hobbies include things like CrossFit, hiking, snowboarding, traveling, cooking, anything to keep my blood flowing and to keep me seeing the world, which you can see here in a couple pictures on the side. And then when I am in the hospital, besides doing surgery, I have a lot of research and clinical interests. I'm interested in complex spine and deformity surgery, malignant brain tumor research, and pediatric neurosurgery. Now, for some of you, you may not have had much experience with neurosurgery, and so I just want to provide a brief outline as far as the field of neurological surgery. Now, the definition is that we're self-explanatory, but we're a specialty that pertains to the surgical treatment of diseases and disorders of the nervous system. Now, very important to remember is that the nervous system is not just your brain, but also includes your spine and your peripheral nervous system. Now, neurosurgery is divided into multiple specialties that I just want to briefly introduce to show you guys that neurosurgery is actually a very vast field. Now, from spine, which is the majority by caseload of neurosurgery, this includes everything from minimally invasive surgery and techniques to complex deformity and scoliosis surgery. Additionally, there's neurosurgical oncology, which includes malignant tumors of both the brain as well as the spinal cord. And additionally, there is open cerebrovascular and endovascular techniques. Endovascular is now catheter-based guide treatments. We can treat things like stroke, aneurysms, arteriovenous malformations, etc., all through a catheter, through minimally invasive means. Additionally, we still perform open cerebrovascular surgery, where we can treat aneurysms or AVMs through open cranial surgery. Additionally, there's skull-based surgery. This includes things such as pituitary tumors, where we do a transnasal or through the nose approach, usually with the help of our colleagues from ENT. Additionally, we can also perform surgeries either accessing the middle or the posterior fossa to access different parts of the skull base. And then finally, we have other subspecialties such as pediatrics. Obviously, that includes treatment of children who have neurosurgical diseases and disorders, as well as functional neurosurgery, which includes things like DBS surgery, which is deep brain stimulation surgery, which historically has been used to treat disorders such as Parkinson's disease, but now we've expanded that role to treat conditions such as depression or OCD. This just shows you here on the right some of the vast breadth of neurosurgery. As we can see here, malignant brain tumors, a cartoon in the bottom right depicting an AVM, and scoliosis surgery seen in the bottom left. Now, there are lots of misconceptions of neurosurgery, and I just want to very quickly address them because I feel like while many specialties have their reputations, neurosurgery often confers a lot. So I want to address some of these. So before I get to these, there are some facts you should know about neurosurgery. As I just mentioned, it's a very diverse field. We operate on all different parts of the body. Again, the nervous system expands the entire body. So we're often seen operating on different parts of the body and not just the brain. Technically, neurosurgery is very challenging. Everyone likes to have the preconceived notion that you must be good with your hands because you're a neurosurgeon. And while you're able to train your hands, it is true that you do need a certain amount of technical abilities to be able to use your hands to perform the surgeries that we do. And that's just by the nature of the high fidelity real estate that we treat. The brain and the spine, especially the spinal cord, are very delicate parts of the body. And so it can be very technically challenging at times. There's a very strong research component in neurosurgery. We're all very academically inclined, at least in the beginning of our careers. Matching into neurosurgery is very competitive. It often requires a very strong research pedigree. And so we look forward to having people in our residency training programs who want to move the field forward and be innovators in the field. Additionally, it's incredibly rewarding. We have the utmost privilege of treating some of the most fragile patients, whether you're a patient with a brain tumor or who has a tumor in the spinal cord or has epilepsy that's debilitating. We're able to surgically augment these diseases and truly make a difference in people's lives. I can't tell you how rewarding it is to see our patients do well. Additionally, neurosurgery, like many other surgical specialties, are very well compensated just due to the nature of the procedures we perform and how we're reimbursed in our healthcare system. Now, some misconceptions I want to address is that there's a misconception that all neurosurgical patients have bad outcomes, that they're comatose, that they have poor functional status. This is not always the case. Occasionally, we do come across a patient who has suffered a severe traumatic brain injury or a high-grade ruptured aneurysm who has a bad outcome. But by and large, the vast majority of our patients have good outcomes and have high functional statuses. Additionally, there's the misconception that you have to be the top medical student at the top medical school to match into neurosurgery. While neurosurgery, as I mentioned, is very competitive, there are a million ways to become a neurosurgeon. You don't have to go to, say, one medical school to get there. There are many routes, and I have friends and colleagues who have been to medical schools both in the United States, abroad, who are DOs, went to DO programs versus allopathic programs. There are many ways to become a neurosurgeon. And what's more important than the name of the school that you went to is how you got there and your work ethic. And that's really what we look forward to. Additionally, there's a reputation that women can't become neurosurgeons. While it is true that we're a male-dominated field, especially historically, like most other surgical specialties, this is definitely not true. Some of the strongest colleagues I have are women. We have several outstanding female residents in our program, as well as female faculty members. And I have to tell you, to be honest, if we have the same candidate that's a male and a woman, we're often going to go toward the woman candidate because women make great neurosurgeons, and we're trying to augment the field and increase the amount of women in neurosurgery. So if you're a female interested in neurosurgery, I highly recommend it. Keep working hard, and I can talk to you more about that. And then finally, everyone thinks it's like Grey's Anatomy, where we're just McDreamy and doing these cool surgeries. But it's not the case. We work very hard and we don't just flirt with our colleagues. So I would say not all of neurosurgery is just like Grey's Anatomy. Now, a brief outline of my path to neurosurgery has really taken me across the country to get here. Started in Philadelphia, then went down to Baltimore to go to Johns Hopkins. As I mentioned, then took a hard left to go all the way out to La Jolla, California, to beautiful sunny San Diego, where I went to UCSD. And then finally, made my way back close to home to come here to Mount Sinai. I'm truly blessed to be at an outstanding institution right in the middle of New York City at one of the busiest neurosurgical programs in the country. So now I want to get started on a case that, if you were tuned in yesterday with Dr. Riley as part of the emergency medicine section, you're very familiar with this patient. So just to give you an idea, this is a 35-year-old male brought in after a high-speed motor vehicle collision. No witnesses at the scene, but he was found mumbling and confused. He was vomiting several times when the paramedics arrived and brought him to the emergency department. He has no other signs of trauma. His chest looks okay, abdomen looks okay. And the trauma team said that from a cardiopulmonary standpoint that he's stable. These are his vital signs, which overall look pretty stable. He's a little tachycardic, not surprising after a big trauma like this. So my question, and guys, feel free to type in the chat box, is what your next step would be. Now I know there's going to be some lag time with the Zoom chat, but we'll keep moving forward, and I'll screen your answers as they come in. But so you see this guy. He looks like he's in pretty tough shape. He's suffered some type of brain injury just based on this initial exam that we're getting. So what we're going to want to do at this point is neurological exam. So CAT scan. So that's a great answer, Nicole. So before we want to get a CAT scan, we have to examine the patient, right? CAT scan is very important. I agree. We need a CAT scan in the first couple minutes, but it's not the first thing we want to do, right? The first thing is ABCs, like always. You have to assess airway, breathing, circulation. You have to make sure they have a patent airway. If they're not protecting their airway, then the patient's never going to make it to the CAT scanner, right? You have to think about the vitals. So after we get done the ABCs, I'm not going to go into that because Dr. Riley did an excellent job yesterday talking about that. We're going to go to that D, to the secondary trauma survey, which includes disability, which is the neurological exam. So this is his neurological exam. So GCS, we'll get into GCS in just a second, but I want you guys to think about this GCS and what this means. Now, his eyes are open to noxious stimuli. That means they're closed until I shake him around a little bit, say, hey, Mr. Smith, wake up, you're in the emergency department. His pupils, I want you to pay close attention to. The right pupil is 4 millimeters and sluggish, and the left pupil is 3 millimeters and brisk. And I want you guys to let me know if you think this is normal or abnormal, and if it's abnormal, why. He has positive cough, gag, and corneal reflexes. Now, these are some brainstem reflexes, which I'm not going to spend too much time going into, but these are important reflexes to know if you have an intact brainstem. Very important in the neurological exam of a trauma patient. Now, he's extensor posturing in the right upper and lower extremities. So this is really important, guys. What this means is that without doing anything, his right arm is extended and pronated, and his right leg is extended as well. Now, this is not normal. You're not going to be extending like this. Sorry, I'm just reading through the chat right now. Right, so this means that you've suffered some injury, actually most likely to the contralateral side of the brain, right? Because if you remember, those descending cortical spinal pathways control the opposite side of the brain controls the ipsilateral side of the body. So the right side of the body is controlled by the left side of the brain, right? He's moving the other side, so it should be the left side spontaneously. He's not following commands. This means when you say, hey, Mr. Smith, you show me 2 fingers, you squeeze my hand, he's not doing it. These are all abnormal signs, right? So getting some comments here. Exactly, perfect. You guys are stealing my lecture from me. I don't even need to teach you guys. GCS 8 or less needs endotracheal intubation. Exactly. This is a classic saying in trauma, GCS 8 intubate, right? This is low GCS. You have to make sure they're protecting their airway. So very important. So we're going to want to intubate this guy. Exactly. So I agree too that the pupils, I wouldn't say it's too big. More important than the size is the relative size, right? Generally, now there are exceptions to this, but generally people have symmetric pupils. There are occasions that you can have physiological asymmetric pupils called anisocoria, but it's not very common. And in this case, I'd be highly suspicious that the reason his pupils are asymmetric is because of the trauma. Nicole mentions a good question of could he have experienced damage to the spine? He could have. In this patient, we definitely want to make sure that we have C-spine precautions. Okay, there's always a chance of spinal cord injury as well. However, in this case, the reason he's extensor posturing is more likely due to an injury within the head than the spine. So our next steps now, and you guys all said it, again, just very briefly going back to GCS, this is a component. This is a coma scale, Glasgow coma scale of 3 components. They include the eyes, the verbal response, and the motor response. Now you guys can see it up here on the screen. I won't go through everything. You all, assuming that you're awake and you haven't fallen asleep yet in this lecture, you're GCS of 15. The lowest GCS is a 3, which is 111 for each category. That's essentially being fully comatose. So this guy at 8 is a pretty low GCS. This is assuming that he doesn't have any drugs on board or anything like that. Any other reason to make his GCS lower. So the next step now is that we have to get a CAT scan. Right, this guy has some very concerning findings on exam. The anisocoria, the difference in pupil size, the fact that he's extensor posturing on one side of his body. Okay, these both indicate that he may have some pressure on his brainstem, which could be very severe and could have a high mortality rate. So we need a scan and we need it fast. So as soon as I get this exam from the patient, I'm calling CT, I'm letting them know that I'm coming right now, right? This is not something that we can wait an hour to get this scan. This is a scan that has to get done now. And this is the scan, guys. So I know it's going to take a few seconds to filter your answers in, but I want you guys to give me your diagnosis. What do you think is going on? Now, just to help orient you guys, this is an axial cut of a CAT scan of the head, okay? Now, important to note, I'm not sure if you guys can see my mouse here, but the left side of the picture, it's actually the right side of the head, okay? And the left side of the picture is the left side of the head. So I think there was a typo on the prior screen. He's actually extensor posturing on the left, spontaneously moving his right side is his accurate exam. I apologize, there was a typo on the screen. So what do you guys think is the diagnosis? You see this. This is a picture of the brain. Okay, good. So hemorrhage. I like that answer a lot. So why do you say that? So the reason that we know that there's blood here is because, again, think about the image. This is a CAT scan. This is not an MRI. On a non-contrasted CAT scan, a hyperdensity that we see in this pattern in this clinical setting is most likely consistent with a hematoma or a hemorrhage. And not just blood, but acute blood. Acute blood will be bright on a CT. Chronic blood will be dark. So this is so I'm seeing a lot of great answers. So it's actually not an epidural hematoma. This is a subdural hematoma. And how do I know that? Type your answers in, guys, what you think as far as why I know, without looking at anything else, that this is a subdural hematoma and not an epidural hematoma. But I agree. It's a subdural hematoma, and it's an acute subdural hematoma. It's on the right side of the head, okay? Not only that, it's creating a lot of mass effect. Guys, look at the center of the scan. If you see those two little butterfly C-shaped things, those are the ventricles. Those are the areas of the brain that contain the CSF, there's cerebral spinal fluid. They're supposed to be right smack dab in the middle of the head, but if you can see, they're all the way shifted over to the right. You'll have to take my word for it, but this is actually a lot of shift. This is over a centimeter of shift, which is very severe. Bleed, you can see below the dura. Well, I would argue that you have a very hard time seeing the dura just based on this slide, but it's where the blood is, which I'll get to in a sec. All right, so we talked about the diagnosis. So this is an acute subdural hematoma. And then what do you think are the next steps you would do for this patient? Now, I want you guys to remember, there are multiple types of intracranial bleeding. There's not just a subdural hematoma. You guys already did a great job mentioning it, that there's also something called an epidural hematoma. Now, I want to go over the different types of intracranial bleeding, just the basic broad strokes categories, so you guys have a sense of what these things look like. So when you see a CAT scan, you can say, hey, I remember Dr. Schupper's lecture. I remember that that's an epidural hematoma. So this right here is the same type of bleeding that we just saw. This is a subdural hematoma. Now, I want you to compare it to this picture, which is an epidural hematoma. Now, the big difference is because one, epidural is above the dura, the other subdural is below the dura. Guys, for those of you who aren't familiar with it, the dura is the covering over the brain. It's the outer layer of the meninges, or the coverings of the brain. It's a very firm, fibrous layer, okay? If you're under the dura, you don't have to worry about the cranial sutures because there's nothing preventing blood from going to different areas on that side of the brain. However, in an epidural hematoma, when you're over the dura, the bleeding will persist until you get to the cranial suture, and the suture will block off that space. So when you see a crescent shape like this, that's within suture lines, which are suture lines are essentially what separates the bones, okay, in the skull, that's an epidural hematoma. Versus a subdural hematoma, you don't have to worry about the suture lines, so blood's just going to fill in that whole side of the head. This right here is something called an intraparenchymal hematoma, or IPH, sometimes also called an intercerebral hematoma, or ICH. Okay, this can be from different reasons. It's most often due to hypertension, high blood pressure. It can also be from a tumor. It can be from a vascular malformation or for something like amyloidosis. And then finally, we have a bleeding pattern like this. I'm not sure if you guys have seen this before. This is something called a subarachnoid hemorrhage. This is most likely from a ruptured aneurysm. It can also be just traumatic. Some severe traumas can lead to traumatic subarachnoid hemorrhage as well. The difference in the bleeding pattern here is blood fills the skull base, specifically the cisterns or the open CSF spaces down low near the skull base, and it creates this almost starfish pattern that you can see here. So these are some different types of intracranial bleeding. Now, why is this a big deal? The reason this is important and why we need to treat this urgently is because of something called the Monro-Kelly doctrine. Now, I'm not going to get too technical with you guys, but it's a very simple concept. I want you to think of a closed cardboard box, like something you get from Amazon, okay? If it's closed, you have a fixed volume, right? In the head, it's the same thing. It's a closed box with a fixed volume. And there are only three things that can be in the head, okay? There's brain, there's blood, and there's CSF, cerebral spinal fluid, okay? Any increase in any of those at a set volume increases the pressure, okay? And increased pressure inside the head can be very dangerous, which we're going to figure out why. Now, very quickly, I just want to introduce this very important topic of autoregulation. Your brain and your head is like a thermostat, where within a wide range of perfusion pressures, of pressure going to the head, you keep your cerebral blood flow, aka you're perfusing your brain adequately. However, when you get to either too high or too low on both extremes in terms of how much pressure is actually going to the brain, this can start affecting the blood flow. And what matters more is when you decrease the blood flow enough, your brain doesn't get oxygen and those areas become ischemic, which is what happens, for example, when you have a stroke. So this is the whole importance behind this. And then what happens eventually when the pressure goes up high enough is you get something called herniation. Now, have you guys ever heard of herniation before? Give you guys a second to type in your answers. Because a lot of you might be looking like this, which is totally fine, because you're like, herniation. Do I know any part of that word? Now, you might be familiar with something called a hernia. Have you guys heard of a hernia before? I'm sure many of you, if you don't know anyone with a hernia, you might have seen someone with a hernia, right? And it's actually the same kind of thing. Your brain can herniate the same way that an intestine can herniate in your abdomen or in different parts of your body. Now, why this is important is because it goes back to the whole idea of the Monro-Kelly doctrine, in that your brain is in an enclosed space in the skull. And when that pressure increases, eventually the brain is going to herniate, is going to go through the skull. And where does it go? Where's the only opening in the skull? It's down, okay? And what's down there is something called the brainstem and the spinal cord. And so what happens is when you put increased pressure on the brainstem, that's really bad. And why it's bad is because the brainstem regulates many of your autonomic functions, such as your respiratory drive, the ability to use your lungs, your heart rate, controlling different aspects of the cardiac cycle, okay? So when these things start to become affected, it's bad news at that point, and often is irreversible and will lead to death. So herniation is the big overlying reason why we have to control our intracranial pressure. Now, I just want to take a step back to remind you guys that even though we're talking about trauma right now, there are many other causes of high pressure in the head and in the brain. These are just, this is a whole laundry list of them. You guys don't have to memorize them, but I just want to introduce a topic that things like infection, brain tumors, issues with the flow or obstruction of cerebral spinal fluid, such as hydrocephalus or tumors in the ventricles, can lead to increased intracranial pressure. So even though trauma in this clinical setting is the reason why, I want you guys to not forget that there are different causes of high pressure within the head. Now, the important thing to know about controlling intracranial pressure is that we have a very standardized approach for how to manage it. And what's really important, and what I want you guys to take away, is that there are a lot that you can do as pre-med students, as medical students who are working or who are shadowing, to help decrease the intracranial pressure of the patient. And you can do this without having an MD, without prescribing the patient any medication, without taking them to surgery and removing half their skull. There are a lot of things you can do to decrease the intracranial pressure. And I'm going to start by talking about them. So initial management, again, going back to Dr. Riley's lecture from yesterday, airway management is the most important thing, okay? GCS 8 or GCS under 8, intubate, okay? This is classic trauma emergency medicine management. You have to protect the patient's airway if they have a low GCS, because they're not going to be able to protect it themselves. And if they stop breathing, nothing else matters. So once you've protected the patient's airway, and in this case, meaning intubate, put an endotracheal tube, so you can hook them up to the ventilator and control their respiratory drive, you can do something called hyperventilation, which will transiently decrease the intracranial pressure, okay? Hyperventilating, you're going to blow off CO2, okay? You're gonna be affecting the pH inside of the head, inside the blood vessels, okay? Which is gonna create a relative transient decrease in intracranial pressure. Additionally, it's very important, you want to avoid hypoxia. You want to hyperventilate the patient to the point that they become hypoxic, right? Because that will also be detrimental and have a reverse increase intracranial pressure effect. Now, what I want you guys to take away is that by doing something as simply as changing the patient's head can decrease intracranial pressure. Now, why do I say this? The most frustrating thing when I come down to the emergency departments, the trauma bay, and see a patient is that they're concerned about a severe traumatic brain injury, and the patient, they're concerned that they have a bleed in their head and the patient's laying flat. And I look at the emergency medicine team, and I'm like, what are you guys doing? You're not understanding what's going on. The first thing I would do is I grab the head of the bed and I lift it all the way up, okay? By increasing the head of the bed, what we're doing is we're encouraging venous outflow, right? Think of what happens when you drop your arm and your veins start getting big, like you're a bodybuilder, right? That's because blood is starting to pool down there, okay? And you're changing the dynamics of blood return to the heart, okay? It's the same thing in the head. Lifting the head up, you're encouraging venous outflow, which will decrease the intracranial pressure. Additionally, just keeping the head straight can actually play a significant role in decreasing the pressure inside the head. Why, you ask? Because how is blood drained from the head? You have two big veins, one on each side, called your internal jugular vein, which drains all of the blood from the head, okay? When you turn your head to one side, what you're doing is you're actually clamping off one of those internal jugular veins. When you're awake and alert, it's not a big deal. However, if you have concerns of high intracranial pressure, this can actually be substantial. So you want to keep the patient's head straight. Additionally, for the same reason, you want to minimize how constrained their cervical collar is. So even if they have to be in a hard collar, you can loosen it. The patient's not going to move anywhere because they're intubated, they're sedated, they're not going to be flailing around. It's not going to be a danger to them. You don't want their cervical collar to be on tight. Otherwise, it will prohibit outflow, venous outflow from the brain. And finally, you want to sedate the patient. Now, again, you have to protect their airway. If you're going to sedate the patient, they have to be on a ventilator, you have to control their breathing. But it's really important because by sedating the patient, essentially, you're decreasing their metabolism and you're decreasing the glucose and the oxygen that the brain is requiring. The brain is a very metabolically active organ, guys. It consumes more glucose than any other part of the body, more sugar building blocks of energy than any other part of the body, okay? So by sedating them, you're decreasing how much energy the brain is requiring. And then again, as you guys did a great job mentioning, you have to image the patient. We're neurosurgeons, we're not magicians, and we don't have a magic 8-ball. If we don't know what's going on inside the head with a picture, we're not going to be able to do anything, or we're not going to have a good idea of what to do. And again, we already went over the imaging as far as the differences. Epidural hematoma on the left, subdural hematoma on the right. I'm gonna knock it into you guys until you have it straight. All right, so after you've done all those things, if you're still concerned that their pressure is high, we're gonna give them some medications. Now, there are actually some really strong medications that can bring down intracranial pressure. Now, some of these medications might be new to you guys, but it's a very simple concept and they work the same way. Essentially, you want to think of where there's water in the brain, right? The brain by weight is mostly water actually. So that gives us a lot of opportunity to suck the water out of the brain, okay? It's mostly in the form of both blood and cerebrospinal fluid. Now we can take all this water out from the tissue, from the brain, and we can do it by creating this gradient. So we can do it with something as simple as salt, sodium chloride in very high concentrations can release the water from the brain, which will transiently decrease the pressure. Additionally, we can use something like mannitol, which is an osmotic diuretic, to do the same thing. In this drug, you have to be very careful. In certain patients, especially with renal disease, with kidney disease, mannitol can be very dangerous. So in the right patient, it can be very effective. And then again, just going back to different reasons to or for a patient to have high intracranial pressure, or high ICP. In a patient who has a brain tumor, we might want to use different therapies. For example, the reason why a patient with a brain tumor might have high intracranial pressure is often not due to the brain tumor itself, but the surrounding swelling that a brain tumor can cause. Now, the way we treat this is with high doses of steroids. Dexamethasone or Decadron is a very potent, very strong steroid that we use in this case. It's actually very effective at decreasing the swelling or edema in the brain. Then obviously in cases of infection, like intracranial abscess, we can use antibiotics to decrease the swelling. Now, these two tiers are happening usually in tandem. Usually we're intubating the patient and we're hyperventilating them and we're giving them mannitol and hypertonics, all at the same time. And this is really to temporize the effect and to see if the patient's responding. If the patient responds to these therapies and their exam improves, great. However, often in the case like we have today, where a patient has a very large subdural hematoma with a lot of midline shift, we often need neurosurgical intervention, which is where we come in. Now, there are several things that we do as neurosurgeons. One, and this all goes back to that slide of the Monroe-Kelly doctrine, that the head is enclosed and the brain is stuck in a closed box. And we have to do something to change the pressure. And the way we do this is we can either decrease the contents or increase the volume. So keep in mind that very simple concept, because that explains everything we do in this case in neurosurgery. So the way that we could decrease the contents, because if we have increased blood in the brain, what we can do is we can actually take off CSF or cerebrospinal fluid. There are different ways we can do that. We can place in something called a ventricular drain. You remember those little C shapes? We can place a drain in those areas in the middle of the brain, drain off some fluid to decrease the pressure. Additionally, we can increase the volume, because if the brain is in an enclosed box and now we open that box, we create theoretically infinite volume now for the brain to expand. We do that through something called decompression, or a decompressive craniectomy, where we remove the bone and we actually keep it off. And then we just suture the scalp back together with no bone on. So if you do this really above the ears up here, it's called a decompressive hemicraniectomy. If you have bleeding in the cerebellum, in that area, then that's below something called a tentorium. Then that procedure is called a suboccipital craniectomy. They're essentially the same thing, just in different parts of the head. This is an example here of that drain that I was talking about that we put in the middle of the head that goes into those little C shapes you saw in the CAT scan, the ventricles. Now, by draining the fluid, that will decrease the pressure inside of the head. Now, I only have a couple more minutes, guys, because I want to leave plenty of time for questions and for us to have a Q&A session. So I just want to finish off by talking about what happens if all these things don't work. Now, most of the time, surgery is very effective. In the case of trauma, in other cases of ruptured aneurysms, but in the case that surgical decompression does not fix the ICP crisis that the patient is having, we go to our last resorts. Our last resorts include things like paralysis. Again, going back to the idea that we talked about with sedation, that by decreasing the metabolic demand of the brain, you're going to decrease the pressure, okay? And the best way to do this is A, to paralyze the patient, right? If they're not moving, then they're not sending signals from their brain to their body and vice versa, okay? They're not interacting with the world and we're going to decrease their metabolic demand. And then finally, our last ditch effort to decrease intracranial pressure is something called a barbiturate coma. I'm not sure if you guys have heard of this, but we can use pentobarbital to totally shut down the brain. Essentially, this is the restart button on your computer for the brain, where we put someone in a barbiturate coma and essentially the brain is totally asleep at this point. Now, this can be dangerous. The patient can become hypotensive. They definitely have to be in an ICU setting for this. Also important to keep in mind is that these drugs stay in the system for a very long time. So it can take actually up to 3 days to reverse a barbiturate coma. So we only do this if we absolutely need it. Now, in conclusion, guys, you guys have been an awesome audience. Thank you so much for participating. I'm really excited for this Q&A to follow. Neurosurgery, it's very challenging. We deal with a lot of very challenging diseases and disorders, but it's so rewarding. We're able to remove people's brain tumors, people who have had unrelenting back pain for years and inability to walk, we're able to give them the power to walk again. People who have struggled with epilepsy for decades, who have not been able to drive or hold down a job, we're able to perform surgery to give them another chance at life, to make them seizure free. Kids with brain tumors and other horrible conditions, sometimes we're able to cure them or give them more years to live. It's really an encouraging, very rewarding field. And I can't tell you enough, every day I have these incredibly rewarding experiences with my patients. It truly is a blessing to be in this position. Again, we operate on very high fidelity territory. Every day we're in the brain, on the spinal cord, very high stakes territory, which is why neurosurgery is such a long training program, because you have to make sure that by the time you get out, you're very comfortable operating in these parts of the body. We're a very rapidly evolving field with technology. We're always adding new things. We're now doing robotic spine surgery. We're using exoscopes for higher resolution optics in the operating room to visualize brain tumors and skull-based surgery. Every day there are new technologies coming out, and we're always on the cutting edge of what's to come. So we have a lot of fun. You can see me here hanging out with some of my friends. Alyssa in the middle is one of our physician assistants. On the left is Abby, who's my co-resident. And then I'm hanging out with Kurt and Trevor, some of my co-residents, placing a shunt on the right. So I'll leave you with this quote, guys, and I'll open up to questions. Thank you guys so much for being an awesome audience.
Thank you so much, Dr. Schupper, for this wonderful presentation. It was so informative, and we all learned so much from you.
Oh, thank you so much.
And I can send in the questions through the Zoom chat if you'd like. Oh,
sure. Yeah.
all right.
Yeah, whatever works best. I was going to make a final plug, just going off Dr. Riley's presentation from yesterday. We actually have a podcast on Apple Podcasts, both Dr. Riley and I, where we talk about different topics specifically aimed toward pre-med and medical students on how to choose a specialty, how to get into medical school, things like this. So I highly recommend you guys check it out. Give us feedback. We're always looking for new topics, and it really is aimed to help you guys in terms of getting into medical school and becoming doctors of different specialties. So I highly recommend it.
Thank you so much. I'm sending the questions in the chat box.
Sure. All right, let's do it. So what percentage of patients put into barbiturate coma actually come back to normal function? That's a great question. I don't have the exact numbers off the top of my head. Usually when a patient goes down that line, if you remember that tiered scale that we talked about, when you get to that last step of barbiturate coma, usually it's kind of a end of the game type situation. So most of those patients don't have very good outcomes. It's not as common anymore. We used to put more patients in barbiturate comas maybe 10 or 20 years ago. It's very rare now that we'll do it. But I would say in general, patients don't have good outcomes who end up needing a barbiturates. It's a great question though. How's my lifestyle of my specialty? That's a great question. We get this question all the time. Obviously, residency is tough. We all work plenty of hours. The reason is because you just have to work a lot. You have to operate a lot to be comfortable enough to be operating on your own after 7 years. With that said, having a work-life balance is really important. I try to show that with my Instagram page and with doing things like this, that you can do a lot of things outside the hospital. I love working out. I'm on Peloton a couple times a week at least. Playing with my dog, going, traveling when there's no COVID around. So I'm always finding fun things to do. So we work a lot, but we also play pretty hard as well. Let's see. All right. Oh, there's a lot of questions. All right, I'll try to get through these. Is it common for patients who undergo neurosurgery to return to their former quality of life? Yes, of course. Obviously, there's variance, just like anything else. Think about a cardiac surgeon, someone who has a bypass, right? You're going to have a lot of patients that return to their prior quality of life. A lot of patients will hopefully return to a better quality of life, right? We operate on patients because they have a disease or a disorder that needs surgical intervention. So a patient with a brain tumor, depending on the type of tumor, we can often cure this disease. And so they'll never have a tumor again. It's very variable. A lot of patients who undergo spine surgery do have improved outcomes, right? Or we wouldn't be doing surgery in the first place. So I would say the majority of our patients do have good outcomes, yes. It obviously depends though on why the patient needs surgery in the first place. Let's see, and I'll just say, trauma days. All right, so someone's asking about trauma. So it depends on the hospital. It depends, A, if you're a trauma center, and B, if you are a trauma center, what level of trauma. To be a level 1 trauma center, you need 24-hour neurosurgery coverage. It's just part of the trauma designation. For our hospital system, we have a level 1 trauma center that's called Elmhurst Hospital. It's one of the New York City hospitals. We have operative trauma multiple days a week there. It's a very busy trauma center. Here at Mount Sinai Hospital, which is kind of our flagship hospital, we're a level 2 trauma center. It's less common that we have operative trauma here. We have more of an elective practice. We do a lot of cerebrovascular and skull-based surgery. So it really just depends on the hospital, but between our whole health system, we have a good amount of operative trauma. Let's see, residency schedule, work-life balance, women with children working with you, was a typical day look like? Sure, that's a great question. I was actually planning on doing an Instagram post soon about kind of a day in the life of a neurosurgery resident. So it's very timely. So my average day, it depends on what service we're on. Some services are busier than others, but on an average day, we usually wake up around 4:45 or so, leave the house around 5:15. I always love working out, so I make my commute to and from work a workout. So I'm always riding the bike. I usually get into the hospital in about 15-20 minutes. So I usually show up to work around 5:30. I pre-round on all my patients. I sign out the overnight provider who was on. I round on my patients. I go into the operating room. I spend all day mostly in the operating room. It can range. It can be as little as 5 hours or as much as 16, 17 hours, depending on what cases we have and how many cases we're operating on in that given day. What time I leave also depends just on the OR schedule. We never know how long cases are going to take or what type of cases are going to come in the middle of the day. It's not uncommon that a patient comes into the emergency room that needs surgery right away. So it's very unpredictable. Some days we can leave at 4 or 5 o'clock. Other days we could be there till 10 to midnight. It just depends. Our days are very variable. I know it's not really a good answer, but you don't go into this field to work a normal 9 to 5. That's not why you sign up to not just be a neurosurgeon, but to be a doctor in general. You're there until the patients who you have to treat are better, or you can hand off to the next person. So in surgery, we're there until the surgery is over. Let's see, and then we have a couple women in our program. We have 2 fantastic female residents. One is our co-intern, one is one of our interns, Halima Tabani, and then another is Ray Fang, who's a 3rd-year resident. Both are fantastic. They're the best female role models I could ever imagine. So I highly recommend you guys check them out. They're also on Instagram. And we have a couple residents with children. Yes. Both of our chief residents have children. Both have 2 children actually. And then we have a couple other residents with children. So you can definitely do it. You have to be flexible. Obviously, you have to have a partner who has probably a more forgiving schedule than your own, but it's definitely possible. Let's see. I hope that summed up kind of an average workday. Let's see. How has my life changed since COVID? That's a great question. Obviously, here working in New York City as a provider, it's been really tough. But honestly, it's been such a privilege. As I mentioned, Elmhurst Hospital, which most of you guys probably never heard of before this year, is now one of the more well-known hospitals in the United States because it was one of the hospitals that got hit the hardest in March. President Trump actually, or I guess former President Trump as of today, actually went out to Elmhurst to visit the hospital because it was so bad. You guys remember all over the news, they were showing freezer trucks because our morgue ran out. And we didn't have PPE. It was a really horrible time. Incredibly humbling to be working in that environment, but we've learned so much from it, and the camaraderie we built as a healthcare community has really blossomed. And looking back now, I mean, we're definitely not beyond COVID at this point. We're still right in the middle of it, but it was such a formative experience. That I was an intern at the time, and to be able to take care of those patients in that setting, you honestly felt helpless at times, but it really brought us back to the roots of why we went into medicine in the first place. And that's the biggest take home, is that at the end of the day, when you strip off the neurosurgery badge and the spine surgeon badge and all these things, we're all just doctors. We're all just physicians. We all went into this to help people. And it doesn't matter if you operate on the brain or you treat kids or you treat HIV patients. At the end of the day, we're all healers, right? We all heal some part of the body. And, you know, COVID really exemplified that. And that we all stepped up to the plate. That doesn't matter at the end of the day if you're a nephrologist or a neurosurgeon. We're all here treating COVID patients. We're all doing the same thing because that's what we signed up to do. And so it really validated going into medicine and this career that we've chosen. And I hope you guys choose as well. Let's see. What specialties do we work with the most? How do you work with families when outcomes aren't ideal? Those are 2 really great questions. So the specialties we work with the most are outside of neurosurgery are ENT or otolaryngology. The reason is, as I mentioned, for skull-based surgery, we often co-operate our surgeries with them. For example, in an anterior skull-based surgery and a pituitary tumor surgery, we generally get access through the nose in a transnasal approach. And typically, ENT surgeons will get us there. They will get us through the nose to the sphenoid, which is part of the skull base, which is the bone in front of the pituitary gland. So they'll get us there, and then we'll take out the tumor, and then they'll help put everything back together because they're much better at dealing with those flaps and everything than we are. It's really tough sometimes dealing with suboptimal outcomes. Obviously, going back to one of these misconceptions, not all of our patients have bad outcomes. Most of our patients actually have very good outcomes. That's why we do this. But occasionally, just going back to the fact that we work in very high fidelity territory and high priced real estate, sometimes patients don't have great outcomes, and that's really tough. Especially when a patient is doing really well before surgery and then is not doing as well after surgery. It can be really tough. I'm by no means the expert at talking to families about this, just because I've only been doing this a couple of years. But at least what I've seen from my mentors who are much better than I am at having these conversations is just you have to be honest. You have to be honest. You have to be upfront. You have to take ownership. There's no way around it. For example, you just have to say, "Hey, Mrs. Smith, I want to let you know that you're in surgery and X and Y happened and your husband woke up and this is what happened. And I'm concerned that he had a stroke or whatever happened. And I apologize. And this is what we're going to do about it." And you just have to be upfront and honest with the patient. Okay. You have to tell them right away, the patient or the patient's family, if you're not able to speak to the patient. And it's tough, but you have to partner with your patients and their families, and they have to trust you, because once you lose their trust, everything goes out the window at that point. Let's see. Do I have an interest? Yes, I have many interests. I'm one of those unfortunate souls that cannot decide what subspecialty I'm interested in because I like everything, which I guess is very validating for me of why I went into this field. I like a few different subspecialties in neurosurgery. Again, I like complex deformity spine surgery. I think it really marries technological advances with physics and math, and it's a lot of measurements and angles and straightening the spine and having the right curvature of the spine. I think that's really interesting. From a research standpoint, I really like malignant gliomas, both brain and spinal cord tumors. I think they're really interesting. They're also really fun cases to do in the operating room. We have a lot of technology to help us take out brain tumors. I really enjoy the surgery. I like the research, and I love the patients and working with neuro-oncologists. And then I also like pediatrics as well. Kids are really fragile, but their brains are really resilient. I'm sure you guys have heard of neuroplasticity, but kids' brains are amazing. How they bounce back and recover from a brain tumor from a surgery is unbelievable. And it's amazing to do pediatrics cases. I really enjoy those. Why did I choose neurosurgery over something like neurology? That's a great question. Actually, a lot of people who go into neurosurgery end up deciding between neurology and neurosurgery. Because if you think about it, we treat the same organs, right? We treat the nervous system. The only difference is neurology treats them through medical means. We treat them through surgical means. I was actually one of those people who didn't decide neurology versus neurosurgery. I ended up deciding neurosurgery versus another surgical specialty because I knew I wanted to be a surgeon first. And then I realized that neurosurgery was the type of surgical specialty I wanted to do. I ended up actually deciding between neurosurgery and something like ENT or orthopedics. But I realized that the only reason I wanted to be an ENT surgeon was to do skull-based surgery. And the only reason I wanted to be an orthopedic surgeon was to do spine surgery. And neurosurgery gets to do both of those. So for me, it was a pretty easy decision. Have I watched Lennox Hill? Yes, I have. Yes. Lennox Hill is actually down the street from us. It's really close to us. And they have an amazing team. Dr. Langer, Dr. Bukvar, they're all amazing surgeons. Can't say enough good things about those guys. I would say the neurosurgery part is very accurate. It's not fantasized at all. I think it's really great what they do. And when they're showing the exoscope and how they do surgery, that's exactly how we do surgery here. I'd say it's pretty accurate. Obviously, some things are sensationalized a little bit just because you have a TV crew in the operating room. So you're more vocal, you're talking about things a little bit more. They're going to show kind of your sexier cases, if you will, like awake craniotomies. But I would say in general, it's a very accurate show, yes. How do I prepare for long surgeries? I'm assuming you're talking about physically. Obviously, we prepare for every case. The night before my cases, I look up the imaging, I learn about the patient, which I highly recommend, especially as a medical student or pre-med student. Any chance you have to just prepare is more important. It is the most important. You have to know what you're doing before you go in there. When I was in San Diego, the chief of surgery had us memorize all of the patient's labs. And if we got something wrong, he kicked us out of the room. He said, "You don't know this patient and you don't have a right to be here." And that was a little extreme, but I think that there's a lot to learn from that experience, that you should go in taking ownership over your patients. And especially in surgery, in the case that you're going to see, you should know who the patient is, why they're getting surgery, the indications for surgery, and what the procedure entails. However, beyond that, preparing for long surgeries is a physical game for sure. For me, it's all about working out and just staying healthy and being active. I can tell you, it's the residents and the attendings who focus on physical fitness and wellness who are the ones who have the endurance to operate for hours and hours and hours. And it's the people who are out of shape, who don't spend time on their wellness, who have a hard time with that. So I think the better shape you're in, the easier it is to stand for hours on end because just your body's in better shape for it. How often do we perform robotic surgeries? It depends. Here at Sinai, we don't do too many in terms of robotic spine. Certain centers feature robotic spine surgery a little bit more than we do. It still isn't as common practice as robotics in other fields. For example, using the Da Vinci in OBGYN surgery or urological surgery. It's more being established now in spine surgery, but it's gaining some traction. So we don't perform robotic surgery very often here. Let me see. Someone asked about, in a field dominated by men, more specifically dominated by white men, are we actively seeking racial minorities? 100%. That's a great question. I got asked this 2 weeks ago at another webinar, and it's so important. We are actively looking for new attending physicians, new residents of color from minority groups, women surgeons. We talk to our program director about this all the time, how we have to diversify our group. We at Sinai, we pride ourselves of having a pretty diverse group. Again, it's hard given that we only have 14 residents, right? You can only be so diverse with 14 people compared to, say, a medicine program who has, say, 200 residents. But we have a Haitian American resident. We have an African American resident who actually was our chief last year. Our female resident is from Pakistan. We have pre-residency fellows who are from Greece, who are from Ecuador. Ray is from China. Alejandro is from Colombia. So we have a pretty diverse group, but we are definitely not there. I'm not going to sit here and tell you guys that we have done a perfect job in terms of diversity and inclusion. But I think as a whole, our institution is, at the forefront of diversity and inclusion and improving the diversity in medicine, especially in racial minority groups. So it's something that we're actively working on. We need to get better. And for any minority students looking to go into neurosurgery, I can't suggest it more. We need more people of color, more women of color, more women in general in neurosurgery, and we're actively doing things to try and encourage that. The way we're campaigning to medical students trying to go into neurosurgery, we're trying to get more women interviews at residency spots, trying to increase the match statistics for women and for minorities. So these are different things we're doing, but again, the work is not done and we have to improve this. How difficult was it to pay off the debt? I'll let you know when I've done it. Definitely have it. COVID's been nice because they got rid of interest rates over the past year, but yeah, haven't paid off the debt yet. Med school's expensive, but it's well worth it. Let's see. I think I have another minute or two. If you guys have any more questions. All right. Can you explain the relationship with neurosurgical PAs? Yes, I can. PAs are amazing. PAs, for those who don't know, are physician assistants. We work very closely with them, and it's a very mutualistic relationship. For those of you who don't follow her, our chairman's physician assistant, Brainy Leslie, or Leslie Schlachter, is an incredible example of this. She's also Insta famous, so you should definitely check her out. She has an incredible social media platform, and she really exposes what is to be a neurosurgery PA, and she's a great role model for other neurosurgery PAs. So I highly recommend it. We work very closely with our physician assistants. We have incredible PAs and NPs, nurse practitioners, who work with us both on the floors in the ICUs, who who work on our consult service and are just in service. And we work side by side with them. We do procedures with them. They're doing lumbar punctures, lumbar drains, external ventricular drains, all these things. They're assisting in the operating room. So it's really a versatile role. And we have a great relationship with them. I can't speak for other institutions, but I feel like Mount Sinai really does an awesome job at having that team partnership between our APPs and our residents and attendings. All right, let's see, last question, because I think we're out of time. It's 2 o'clock. How do you cope with burnout and take care of your mental health given the strenuous nature of the cases? That's a great question. It's really hard. I'm not gonna lie to you. I know, Instagram is perfect, right? And everyone just sees these like amazing things and your life is perfect. But burnout's tough. It's really hard. It's been a really hard year, especially with COVID, not being able to travel, not being able to see your loved ones. These are all added stressors that lead to burnout. I think that's why, for me at least, keeping a work-life balance and working on my mental health actively every day is really paramount to preventing burnout. You have to love what you're doing. You have to have a great relationship with your friends and family and do things that keep you going and continue to pursue your hobbies. Don't give up your hobbies just because your schedule gets tough. These are all things that will prevent burnout. Make you just enjoy your life and be happy with what you're doing. So I think that's probably the last question because we're just about 2 o'clock now.
Thank you so much again, Dr. Schupper, for presenting for us and answering all of our questions.
No problem. You guys have been an awesome audience. Thank you so much.
Thank you. Everyone, make sure to check out his socials and his podcast.
Additionally, thank you all so much for attending. The Google form link has now been posted in the comments, so please fill it out within the next 30 minutes. Again, thank you so much, Dr. Schupper.
Thank you, guys.
The form is now also in the description of the video.